right, friends, welcome back. Happy Monday. I hope your Monday is going well. I hope you're listening to this bright and early on a Monday morning because you're freaking stoked that a new episode dropped.
Yeah.
Yeah. Of course you were. Don't you have notifications turned on by now?
Yeah. Get with it,
Please.
guys. Please listen.
Yeah, so today we're talking about HIV and AIDS part 2. So like we said, this topic is just huge. I do think in the future we're going to end up revisiting this and talking about a lot of stuff that we didn't have time to talk about. But I'm excited because we're getting into more recent times, and just a reminder that like HIV and AIDS is still very real. And
yeah, it didn't just magically go away.
Yeah, I agree. I'm going to get a lot more into what clinicians should be doing in general and like how we can help this population, which I have thought so much about recently, and about how I should change my practice around this. So I don't know. I don't think I've said this to you yet, but this podcast has been really great for me, because I'm having to not necessarily relearn, but like dig up a lot of information I haven't had to before, or excuse me, I should say I haven't had to in a long time. But then also I'm constantly like, how can I change my practice to incorporate this? And I do feel like it's making me a better PA. So
yeah, it's not helping me in my normal job for some reason, but I am having a good time.
Having a good time. All right. Welcome, Cadaver Crew.
Get your dark little minds right and settle in.
Class is in session and the cadaver is already on the table.
I'm B.
And I'm Sam.
And this is the Cadaver's Lessons.
So yeah, quick recap. HIV, AIDS. We're talking about the immune system. Remember that this is a virus that comes in and directly attacks the body's immune system and makes it unable to fight off infections. And so that's the fear here. It's not solely related to sex or anything like that, which we covered last episode. We've learned it's transmitted through many different things, even like perinatally through the vaginal birth canals. And so just kind of breaking down some of these myths and remembering, this is more than what a lot of people realize it is.
Yeah, I think if you were to, go ask a random person what they thought about HIV and AIDS, they'd probably name a few people that were famous that had it. And then they would be like, it's a sex thing.
Yep.
That's it. So yeah, knocking those myths away, some of those things you thought you knew.
That's
actually, I years ago heard about this topic on a different podcast called You're Wrong About. And it was so interesting because their podcast is so interesting to me because the whole premise is we're wrong about these topics that we think we know. And I totally agree.
Yes.
And we get these preconceived notions and ideas that this is what that thing is about. And then we just stick with it and it sticks in your head and in your brain. And so it was really interesting listening to their point of view about it. So if you're interested, go check them out.
Yeah.
So we kind of left off historically at 1981. So that's really when the epidemic officially began. We know that it was happening long before then, but that's when we kind of get the, wow, this is a real thing. And then they give it its actual name and we hear the word AIDS. So finally, in 1982, doctors recognize that AIDS is not limited to gay men. We're talking about a lot more people. This is going across multiple different populations, including heterosexual adults and infants and children.
Yep. So like maybe we should take it seriously because we love those babies.
Yeah. I love our baby.
I love our baby. We love babies.
We love babies.
I hope everyone understands the undermining comment there.
So this confirms that AIDS is a bloodborne and sexually transmitted disease. Lots of different ways, like you said earlier. Fear increases and there's no treatment and no cure. So you can imagine this is fuel for a lot of people to use later on in order to influence other people. So there's a lot of fear happening and that causes a lot of hate and targeted aggression towards minority groups who people believe are the cause or the dangerous people that are going to go spread this around. So in order to help provide valuable information to marginalized communities, there were multiple activist groups that were started with the intent of sharing information and fighting for policy and access to medication. Because we'll get into it because the meds, they were really hard to come by.
And doesn't it just like I'm so thankful for these activist groups and their willingness to push this and to do the right thing. But like It shouldn't be up to the people.
So this first group we're going to talk about, I thought it was really cool. It's called the Sister of Perpetual Indulgence, formed in 1982, a gay activist group that published Play Fair, a sex-positive, humorous education manual targeted at gay men advocating for safe sex to avoid AIDS and other STIs.
Beautiful.
Right?
Beautiful. Like, because let's just say, like, even now today in the South, they're not teaching you about sex or body anatomy or anything like that. You know, I don't think I've brought this up on the podcast, but like,
I knew you were going to bring it up at this moment. I should have left a comment in the notes like, Sam is going to bring up the lack of sex education.
Yes, I had no sex education growing up. I had no true anatomy class until PA school, because my college anatomy class was more about histology, so looking at cell slides and being able to tell what it does and then function, but I had no true human body anatomy class until PA school. So all of my sex education, don't know where it came from. So let's just keep it in mind that like none of that's going on.
Yeah, I had sex education.
So Pacific Northwest on one hand, Southeast on the other hand.
Yeah, we watched lots of videos,
as you should.
Movies. It's very informative. So this is really cool. 2 of the sisters were public health nurses, one of whom was named Bobby Campbell, who already had Kaposi's sarcoma. And we talked about this last episode, but this is a cancer that occurs.
It's an AIDS-defining illness,
which you're going to talk about later
today,
in this episode. So I'll let you cover that because I'll stick to the history. So they consulted with doctors to produce the work and distributed it for free at San Francisco's Gay Freedom Day on June 27th.
I love this shit. I love
Isn't
this.
that so cool?
Yeah.
This was really the first pamphlet to educate people on having safer sex.
And it all came because of an epidemic.
Yeah, not a great reason for it, but this epidemic further on as well is really the start of sex education.
Yeah.
And the education about condoms and safe sex in general.
It was time.
Yeah.
Yeah.
The 80s, like, finally, come on.
Yeah.
So they also staged one of the earliest fundraisers for HIV and AIDS in June 1982 and would continue to raise money for HIV positive individuals.
We love them. We love these sisters.
On the other side of the country, so that was happening in San Francisco, is in New York City, the Gays Men's Health Crisis was established. It's one of the oldest AIDS service organizations. Still exists.
Love.
And this was really cool. They set up a crisis counseling hotline, which became known as one of their greatest services. And it was really just someone's landline in their house.
Of course it was. One person doing all the work.
Right. And so I think they just take turns at the landline, but it's so funny. And if you're a young listener and don't know what a landline is, just look it up.
Look it up.
I'm not explaining that to you. So that was another really cool activist group. And they would go on as well to try to influence policy and bring attention to those in need and change and challenge medication prices and further on and really try to drive Congress and the White House into making some decisions or doing anything. The San Francisco AIDS Foundation was founded as a nonprofit organization dedicated to providing services for people with HIV and AIDS with a mission to end the epidemic in the United States.
Later in your notes, do you have the goals of 95, 95, 95 by 25? No, I should have written it down in my notes. It's my fault. But there was this huge goal after all of this. And I don't remember if it's by the United Nations, World Health Organization, or just inside of the United States. But essentially it was that 95% of people would know that they have HIV or AIDS. 95% of the people would be in treatment for HIV or AIDS, and then I forget what the other 95% was. And the goal was it was either 2024 or 2025 off the top of my head. And I hate to tell you, but we didn't meet those metrics because we just push it to the wayside and don't actually help these people.
Yeah, I know we're focusing on the United States a lot when we talk about this epidemic, but this is worldwide.
Yeah.
Does that make it a pandemic?
It does indeed.
Yeah. So it's a pandemic, but we're focusing on
the
United States a lot and their reaction, but this is happening everywhere. So I wanted to put this in here because I think this really captures what the White House was doing about the epidemic in the United States.
Oh, I can't wait for this. I'm sat. I'm ready.
So during a White House press briefing, a journalist questions Larry Speakes, President Reagan's press secretary.
Pause. Fantastic name for a press secretary.
Larry Speakes.
Fantastic.
I think that's how you say his name. Also another asshole, so I don't really care. So this press secretary, journalist asks him about the president's reaction to the AIDS epidemic, which at this time was affecting around 600 people, which is still a lot, especially in the groups that it was affecting. And okay, if it's being reported for 600 people, it's probably twice that.
Absolutely.
So when the reporter mentioned the disease was known as the gay plague, first of all, if you're a reporter using that in the White House press briefing,
not a place.
No, don't do that. So the press pool erupted in laughter. Everybody thought that was hilarious
Of course
to call it the gay plague. And then rather than provide an answer, the press secretary said, well, I don't have it. And then proceeded to question the journalist if he had AIDS. So this is the level of engagement we're talking about here.
Yeah. Makes me so mad. But once again, we've defined who they think this group affects. And it's a them issue, not an us issue. And we're just going to see that time and time again in history. And it always makes me sad.
Yeah. So by 1983, the CDC announces all major routes of transmission, mentioning that it's not transmitted through casual contact like food, water, air, environmental surfaces, and establishes a national AIDS hotline, while also reporting that most cases are amongst gay men, injection drug users, Haitians, and people with hemophilia.
Okay, but why are the people with hemophilia?
I don't know how in-depth they did it. That announcement was made from the CDC. I imagine news outlets took it and did what they wanted with it. So many governments, not just in the United States, but worldwide, responded slowly or not at all due to stigma and political controversy.
Yes.
So though the New York Times initially reported on the illness in 1981, and this is an example of press being biased, it didn't actually make the front page until 1983 after more than 600 people had already died.
And people could have known about this. Once again, I go back to that quote that I saw that we were never supposed to know this much information. And I'm like, I disagree. We're supposed to have access to information.
We can handle it.
We can handle it. And if you can't, let's figure out how to, because even if you don't want to know that information, it's still going on in the world around you.
It's important. Here's a quote from a reporter who used to work for the Times. And he says, quote, "There were strong messages that you got that were not written on any whiteboard. You knew to avoid it. It was a self-reinforcing edict. Don't write about queers."
Write about queers. Okay.
So to make it through congressional opponents, which there was many, in order to get the first federal funding for AIDS and get that approved through Congress, the research had to be coupled with toxic shock syndrome and Legionnaire's disease in a public health emergency trust fund.
So let's just talk about how much these aren't related and shouldn't be under the same funding. Like toxic shock syndrome, my first thought, and there's other causes, but my first thought is women and tampons, right? And so I guess that could be related to HIV and AIDS. And then Legionnaire's disease, why are these all getting lumped together?
Yeah, I think they were trying to hide
absolutely
AIDS in there, and they were like, hopefully we get some funding. This same year, President Reagan cut budgets to the CDC and the National Institution of Health.
Sounds familiar, man.
So activist Bobby Campbell appeared at this time with his partner Bobby Hillard, and you can see this is a reoccurring theme throughout my notes here and throughout the history of HIV and AIDS. There's a lot of really famous people and activists that are running these nonprofits and these organizations that stand up and this one here gets on the cover of Newsweek titled "Gay America, Sex, Politics, and the Impact of AIDS," and then die the very next year. This is a common theme.
What are they dying from?
AIDS.
Okay. Not from government. Sus.
No. They're almost it was really quite sad when I was doing the research. So a ton of people that were activists that were leading these nonprofit organizations had HIV and AIDS.
Yeah.
And so they literally are fighting. Nothing gets done, and then they die. And it reoccurs year after year after year. And it's very, very sad. I didn't put them all in here. I'm not trying to depress everybody so much on a Monday morning.
We do that already.
We do enough already. So at this time, and remember we're in 1983, AIDS cases have now been reported in 33 countries. And in the United States, there is 2,800 cases of AIDS reported and 2,118 deaths. And so just the death rate is
is so high. Just want to take a step back when we say those statistics. Is that specifically AIDS cases that have been reported? We're not talking HIV. We're talking about the progression from HIV to AIDS, which has a very high mortality rate, as we can see. And so think about how significant this is in terms of just people that have HIV at this point.
And has a really long incubation period.
Yes.
Right. So you know that in 1983, if these people are dying from AIDS, that they had HIV maybe even 10 years ago.
Yes.
And it wasn't even on people's radar then. Moving on to 1984, here's a case. I'm not doing the case file on this person. I am doing a case file on a different person that has a similar background. Okay. But if you look up anything about HIV and AIDS, this kid's name comes up.
Okay.
His name's Ryan White. A 13-year-old hemophiliac from Indiana becomes infected with HIV from a contaminated blood treatment. 13. And I may talk about it later, but I'm going to say it now. In the next year, he is barred from school and becomes a national spokesperson against AIDS, stigma, and discrimination. So there was a literal petition from parents at the school that he went to that was signed that said, you cannot go to school here anymore.
Because you sitting next to my kid, you're going to give him HIV.
So he literally got kicked out of school at 13 because of something he had no control over.
Yeah, no control.
And it's not like he's trying to go bleed on everybody. Like, what are we doing here? Come on. So the CDC identifies that needle sharing is a transmission method. It's like, where you been?
We've been known this.
We know this. And then U.S. scientists confirm that HIV is the cause of AIDS. And this discovery allows for diagnostic testing and targeted drug research. I did think it was interesting. There's a big competition between French and U.S. scientists in this.
Interesting.
And so each one claims that they had the discovery first. It's so funny to me. I mean, I don't care who did it. We did it, and now we need to use that information appropriately.
Yeah, we did it, and it took too long, and we're still going to drag our feet.
Yeah. So public fear remains high. Misinformation is spreading all over the place, even as doctors are testifying before Congress on the need for AIDS research dollars and pleading for protecting the rights of people with AIDS. So people are going in front of Congress, doctors, going in front of Congress and saying, we need to figure this out. And people are still spreading misinformation just because they're hateful.
And that's happening right now again. Okay, I know I keep alluding back to this, but I just want... This HIV and AIDS has made me feel so strongly about repeating history and how if we don't know history, we're just going to repeat it. But we have doctors right now that are going in front of every stage they can possibly get on and begging for funding, for correct information to be spread, for all of those things. Yeah. And we're still not getting it.
Yeah.
Sorry. Off my soapbox.
For now.
I'll be back. Don't worry.
So by the year end, there's 7,239 cases of AIDS and 5,596 deaths.
Wow, that is a skyrocket.
That's a big jump, right?
The year before?
Yeah, 1 year.
1 year. Wow.
So 1 year later, we're moving year by year through this, guys.
1985.
The first HIV antibody blood test is approved. Blood banks finally begin screening donated blood, reducing transmission through transfusions. But we also know from our case file that was not always the case.
Yes.
Because they continued to do that almost 10 years after this. Ronald Reagan now publicly mentions AIDS.
Just now.
In 85. And in 82 is when it was called an epidemic. So it's been 3 years and now we're like, oh yeah, we'll mention it. And then he's calling it a top priority and defends his administration's response. And then a month later, Congress allocated nearly $190 million for AIDS research.
Let's just keep in mind, this is 40 years ago. That's way more than it sounds like now. That's
a lot.
Shit ton of money.
That's actually, I believe it was $40 million more than they originally even asked for.
Yeah.
But let me tell you this. An actor, Rock Hudson, dies from AIDS the same day. And he happened to be a close personal friend to Reagan. So when it hits home, it matters.
It always matters when it hits home. Always, always, always.
If it's happening to you, it matters. And this is just a so important lesson in empathy.
Yeah.
And being able to connect with people and understand that people are struggling. And
we've had a lot of talks about this week.
It's on our mind.
Okay.
So it's on your mind.
Yep.
Because you have to listen to us.
You don't know that people are going through their shittiest weeks and we should just be kind to them.
Yeah. So schools, workplaces, and hospitals struggle with discrimination and fear. As I mentioned earlier, Ryan White, 13-year-old, is barred from school And then he eventually becomes a national spokesperson against AIDS, stigma, and discrimination. And there's lots of pictures of him with famous people. He's like invited to a bunch of dinners, but unfortunately he does not have a happy ending.
Of course he doesn't. They never do.
So the U.S. Department of Defense does their due diligence and announces it will be testing all new recruits for HIV and will reject those who test positive.
I love the testing. The rejection just makes me mad.
It's very interesting. You know how you were saying that a doctor that you used to work with thought blood was sterile?
Yes, when he graduated med school.
Yeah. So when I was doing mass casualty training at West Point, one of the things we do are like nasal pharyngeals. So, tube up your nose that goes into the back of your throat, essentially. And one of the things they would tell us was like, oh, if you don't have any on hand, like lube to stick it up their nose, just use like their blood or your spit and stick it up their nose.
Absolutely not.
So I guess I understand in a combat situation.
If you don't have that airway, they're dying anyways.
Right. And I guess I understand like if you are bleeding in a combat situation and somebody is trying to appropriately tourniquet you or pack you or whatever, and they are also bleeding and wounded, there's a high chance that you're spreading HIV.
Yeah. Okay.
So like that portion, I understand. And there's no meds.
There's no meds. That's
right now.
So we can't get to a not transmissible point.
Right. So I guess I would say that's a hard one.
That's fair.
For me.
That's fair.
I think that they probably were using it to reject gay men, probably, yes. And not just HIV positive people. But when you think of it as wound treatment, especially in combat or traumatic care, mass casualty, I think it makes sense for medics and, just your everyday soldier trying not to worry about if they're going to contract HIV.
I can understand it.
But, I mean, that's just my opinion from a, nasal pharyngeal that was shoved up my nose.
Times.
So in 1985, continuing on that train, the American Foundation for AIDS Research is founded with the help of movie star Elizabeth Taylor.
Elizabeth Taylor. Do you think it's forever?
Yeah, T-Swift coming in.
You weren't ready for that.
I was not prepared. So AIDS is now in 51 countries, and in the U.S. we have over 15,000 cases and over 12,000 deaths.
What's that graph called where it's not a straight line across, but it like this is exponentially growing?
I like how you draw the graph with your finger to get to exponentially.
I got there by myself.
If you're watching the video, that was a good one.
But very seriously, like this is exponentially growing from year to year.
Yeah.
Like bad. 600 to 1,000 to 7,000, 15,000. Like this is bad.
So 1986 National Academy of Sciences report criticizes U.S. response to the epidemic and calls for a $2 billion investment to combat disease.
They said, yeah, it's time. Let's go. That little $190 million you gave,
not enough. So now we see the first clinical trials for AZT.
Never heard of it.
It's an antiviral drug. I'm not going to be able to say that correctly. Azidothymedinir.
Okay. AZT.
AZT. That's why they have the acronym for people like me. And so those clinical trials are starting up. And the U.S. Surgeon General Everett Koop issues a report on AIDS calling for a nationwide education campaign, including sex education in schools and increased use of condoms and voluntary testing in October of that year.
U.S. ends that year with 28,000 cases
and just over 24,000 deaths.
Goodness gracious.
1987. AZT becomes the first FDA-approved antiretroviral drug, and initially, it's $10,000 for 1 year supply.
$10,000 of 1987 money.
Of 1987 money. That's a lot of money.
So much.
It's the most expensive drug in history to that time.
And there's this crisis going on, and pharma is like, now granted, do I also understand that maybe it was really expensive to make, to distribute all of those things? Yes. But at some point, pharma has to be like, you know what? We'll make it back. We'll make it back.
Well, privatizing everything. That's want to make a profit, turn the profit. So this drug also has significant side effects, and it's only partially effective when used alone. So that's why it's not very popular. Then I love this. ACT UP, standing for AIDS Coalition to Unleash Power.
Hell yeah.
A major AIDS activist group forms in New York, 1987, pushes for faster drug approval and demands government accountability. And they come up over and over and over again. These
Badasses.
Yeah, they stage things like laying out in front of the stairs of pharma companies and of the government, and they just like pretend that they're just like dead bodies laying on top of each other just to show the impact of how many people are dying. So they go all out.
We love them.
With peaceful protesting. The U.S. government bars HIV-infected immigrants and travelers from entering the country at this time. This is another big thing that activists come out and fight against, is that you're preventing people that maybe are coming here to receive treatment.
Yeah.
And you're just, picking and choosing who you think are HIV positive.
Yes. Yeah. AKA these minorities.
Right. So now we're up to 50,000 cases and 40,000 deaths.
Goodness gracious, 4/5 of these people are dying.
Yep. Congress finally passes the first comprehensive AIDS legislation. Finally.
Yeah.
88 after, reminder, 82 was the start of the epidemic.
81 was when it was defined.
Yeah.
Yeah.
The HOPE Act of 1988. Also at the same time, the first World AIDS Day, December 1st, is declared by the WHO.
It's time.
The WHO. A group of researchers then designed a study that involved treating mothers with AZT from the second trimester onward, as well as at the time of delivery, and treating the infant with oral AZT. The study proved enormously effective in reducing mother-to-infant transmission from 26% to 8%.
That is significant.
Yeah.
The only thing I bet they didn't do any testing on is what were the effects of this antiviral medication on pregnancy, on the fetus, all of those things. But also, I guess the question is, like, what are the possible side effects versus knowing that your kid's going to get HIV, and there's very little treatment at this time, so likely progressing to AIDS.
Risk versus reward, I guess.
Yeah.
Or risk versus risk.
Yeah, risk versus risk, for sure.
Also at this time, every household in the U.S. is mailed a brochure titled Understanding AIDS in order to increase awareness and stop misinformation. The city and county of San Francisco establishes what becomes the nation's largest needle exchange program. So this is where you were talking about last time, I think, a needle exchange or drop boxes for safe injection sites. And so that's really starting here in 1988 in San Francisco.
Good.
ACT UP.
ACT UP.
Our guys ACT UP demonstrates at FDA headquarters to protest the slow pace of AIDS drug approval. So they were forcing essentially the medications and treatments to go through very, very, very rigorous clinical testing they needed to show like years after effects, and these people didn't have years. So they were really pushing for other ways to approve the medication faster and get it into people's hands.
Yeah, which is such a hard line to tiptoe on.
Yeah.
Because we do want to know long-term risks and side effects and adverse reactions, all of the things of these medications. But if people are going to be dead anyways, throw the kitchen sink at them if they're willing to accept those risks.
Yes, as long as you're clear about that and they're willing to accept.
Yeah.
So as we move into the 1990s, U.S. Congress creates the National Commission on AIDS, and activists come out and protest about AIDS drugs some more, including a large demonstration on the Golden Gate Bridge.
I love these people.
They're not messing around.
They're not, no.
There's limited drug options available to these people that are suffering. Patients often take AZT alone, which leads to resistance. So that's why you can't take it by itself.
And we know that there's super high viral resistance in HIV.
The Americans with Disabilities Act, enacted by Congress, prohibits discrimination against individuals with disabilities, including those infected with HIV and AIDS, as we move into the 90s.
Yeah, because if you're just sitting at a computer next to them at work, you're probably never going to get it from them unless you're partaking in some practices. They should be able to still have a job.
Yeah, absolutely.
Congress pay for their $10,000 medications.
Right. Okay. Congress then also passes the Ryan White CARE Act, which is Comprehensive AIDS Resource Emergency Act, a program that becomes the largest provider of services for people living with HIV and AIDS in the U.S. So this is after our kid who was kicked out of school because he had, at 13, because he had a blood transfusion and got
HIV.
He then dies at 18, a month before his high school graduation.
It's just like you realize how quickly people are going without medication.
Yeah, so he's 13, he gets it. He fights for HIV and AIDS rights and resources, and then doesn't even get to graduate high school.
Yeah.
Data also indicates that while Black and Latino women constitute just 19% of all U.S. women, they represented 72% of U.S. women diagnosed with AIDS.
Why? Because of a lack of access to resources, because of a lack of access to education, because of some sort of sexual abuse. Like we have to ask ourselves why.
Lots of reasons and factors I think are playing into that.
Yeah.
But I think you're right. Like good practice. If I'm somebody that's receiving this information and reading it in a report or on a newspaper nowadays on a feed somewhere, I'm asking myself, where did this statistic come from? And why is it important? And why is it like this?
Yeah.
Right? Also, to date, nearly twice as many Americans have died of AIDS as died in the Vietnam War.
Substantial amount.
So, if you just think about that, like how detrimental the Vietnam War was to our armed forces, twice as many people in Americans
alone
have died from
by
AIDS.
1990.
By 1990.
Yeah.
1991, the red ribbon becomes the symbol of AIDS awareness. Now, if you see the red ribbon, it's for AIDS. That's what it's for. If you didn't know,
now you do.
Now you do. Researchers find that HIV is much more likely to be passed sexually from males to females than vice versa, and confirms the conclusion with a 10-year study of heterosexual transmission of the disease.
I'm glad they were doing studies on both homo and heterosexuals.
Mm-hmm. Now, this is probably where a lot of people are like, oh, that's what I connect this epidemic to. So this year, 1991, Freddie Mercury, lead singer of Queen, dies of AIDS, and then basketball star Magic Johnson announces he is HIV positive, and this really starts changing the public perception.
Because it's someone that they idolize and they feel like they know, even if not on a personal level, and it's someone that they've held up on this podium. So now it's not just them, it's someone that they believe in, you know what I'm saying?
And respect. Congress enacts the Housing Opportunities for People with AIDS Act of 1991 to help provide housing assistance to people with HIV and AIDS because they're being kicked out of their places they're living.
So sad.
We're now up to over 206,000 cases and 156,000 deaths.
Those numbers are staggering.
As we move later into the 1990s, HIV becomes the leading cause of death among all adults aged 25 to 44 in the United States.
Time to get real serious about it.
It's been time. It's been time.
I agree. I'm just
Get it together. Women and heterosexual transmission are increasingly effective. Both the Democratic and Republican national conventions are addressed by HIV positive women. So this is turning extremely political. You see political campaigns really addressing this and using it to buy votes.
Absolutely,
right?
as people do.
And on multiple sides, right? Trying to get people to buy into funding for a cure and also using it as a way to spread hate against minority groups and use that to buy votes as well. Ruth Greenblatt and her team create a women's HIV program, an innovative multidisciplinary program specifically for women designed to meet their unique health issues, which I thought was really cool.
Because there's, like we said, perinatal and through breast milk and everything else. It's important that we're addressing this.
Yeah, absolutely. The FDA issues new rules that allow accelerated approval of new AIDS drugs based on lab tests instead of long-term clinical outcomes. So now we're turning that corner. All those activists' hard work, it's making a difference.
Yeah, we make a difference.
And then President Clinton now establishes a new White House Office of National AIDS Policy, and researchers realize that combination therapy is necessary to stop viral resistance.
Which we're still using today.
Yeah. It's just amazing how long this is taking.
Yeah.
Long time. Yeah. So now we're up in the United States to 441,000 cases and 270,000 deaths.
One thing that we're not really talking about, but we're starting to see a gap in the number between the amount of cases and the amount of deaths. Yeah, we're no longer at that 4/5 mark where almost everyone is dying. So we are seeing that treatment is working or that we're able to identify AIDS sooner. And so we're just seeing it before people are dying. Either way, it's a win.
Yeah. As we reach the midpoint of the 1990s, Jeff Getty, a prominent AIDS activist, receives the first bone marrow transplant from baboon cells that were transplanted with the hope that the primate's natural AIDS resistance would boost his immune system.
Did this work? I haven't heard about this.
Yeah, I don't
think so. Or
I
else
don't
we would
it
use it
wouldn't
more.
yeah, it didn't work like they thought it was going to work.
Yeah.
But the idea was that if the baboon cells were immune to
Yeah.
AIDS, then yeah, but I don't think sharing bone marrow with
No. We also determined last episode that in primates it's a different virus.
Yeah, I'm going to forget what it is.
SB.
SMV,
SBZ or something.
SB.
Yeah, something like that.
Somebody
SZV?
correct us from our own notes. It's
Yeah.
in this notes right here. I just am not scrolling up.
No.
Wow. Okay. Also, the introduction of protease inhibitors is a major breakthrough. Viral replication mechanisms become better understood, and hope grows for effective long-term treatment. So this is midway through 1990. So 1995, and we started at the beginning of the 80s. So
Yeah.
almost 15 years. And people
Yeah.
are now starting to
Feel
maybe have hope
for the very first time.
So now it really changes because in 1996, we have heart therapy, or HART, highly active antiretroviral therapy is introduced. So it's a combination of 3 or more drugs and suppresses the viral load dramatically. AIDS death rates drop rapidly in high-income countries. So specifically high-income countries like the United States, we see the drop in deaths, but this is not affordable or available for low-income countries.
Yeah, which we're still seeing today.
HIV becomes a chronic, manageable condition for those with access to treatment, and the International AIDS Conference declares a turning point in the epidemic.
Things are turning around, but only if you have money, if you were born in the right place, if you have access to it.
Right. So as we reach the later half of the 1990s, AIDS deaths fall by over 40 to 60% in countries with access to HART. Long-term side effects of treatment emerge. Stark global inequality becomes clear, as we kind of just alluded to. Life-saving drugs are widely available in wealthy countries and largely inaccessible to low-income nations, especially Africa, where there is a lot of cases. President Clinton calls for the development of an AIDS vaccine by 2007.
We don't have an AIDS vaccine.
Nope.
Yeah.
That didn't happen.
No.
He just asked for it.
Well, we all know how that goes.
Right before the turn of the century, HIV and AIDS causes more deaths worldwide than any other infectious disease. There are over 30 million people living with HIV globally. International pressure builds to lower drug prices, expand treatment access, and the focus shifts from emergency response to long-term global management. So this is where I stopped my notes. There is a lot more about global politics and the response worldwide when it comes to AIDS, but it was a lot. And you know how you had said this could have been 4 different episodes.
Yeah.
It really honestly could have. And so I didn't get much more into the history, but just know that throughout still, so from 2000, where I ended my notes here, to current present day, there is still lots of people suffering and there is no cure.
So I know Bernie today talked a lot about AIDS, and it actually transitions perfectly into the modern medicine because let's remember that AIDS is defined as a CD4 count as less than 200 or one of these opportunistic infections of AIDS. And let's also remember that these infections take place because we don't have the immune system to fight them off. So many of these infections we are exposed to and or acquired. We have acquired early in life as totally immunocompetent individuals, but it's intact inside of us because of
it's like a ticking time bomb.
Yeah. So we have an intact immune system. So most of us never see these, but I just want to make it very clear that these infections are not just AIDS infections. Like we just have an immune system that's able to fight them off. There's a super high mortality rate even now because we have to remember that we at this point don't have anywhere close to an intact immune system, and it's really hard for the body to fight off these different infections. And then we talk a lot about CD4 counts in the medicine. I just want to note that a normal CD4 count is greater than 500. And so that can kind of give you a range of what we talk about because one of these is like super high risk when we get to a CD4 count of less than 50. And so it's like a 10th of a normal CD4 count. So kind of broke these up into different organ systems, and we're not going to get super duper detailed with all of these because A lot of these would make really great individual
Mm.
episodes. First one, tuberculosis. This is super duper common and is unfortunately super deadly. Oftentimes these individuals have latent TB, which means it is in the immune system, but it's not active. It's not causing any havoc on the pulmonary or immune system in general, and it's not transmissible. But because we have this weakened immune system, it allows for the latent TB to become active and begin to multiply inside of the body. Signs and symptoms we're looking out for is fever, unintentional weight loss, fatigue, night sweats, and productive cough. You know, the medical people that are listening, a lot of those are what we call our B symptoms in terms of cancer. So unintentional weight loss, night sweats, and fever. And so just understanding risk factors with our patients, as we've talked about, is super important to being able to determine, am I going down, you know, a malignancy route, or am I going down an infectious disease route in these patients? Also, just like vague respiratory symptoms in terms of sore throat, which you can imagine. I didn't know this before now, but TB, tuberculosis, can affect more than just the lungs. It can also affect the kidney, spine, and brain. So yeah, I never knew that before. I just
So
thought it
all
was
around,
interesting.
not so
about
great.
time.
Don't want the TB.
Okay, the one that I did not look up the pronunciation for last week,
Oh, you pulled a me.
pneumocystitis. I pulled a you. I got the pronunciation guide ready to go. Pneumocystitis jirovecii pneumonia, but we all just call it PJP in the medical world, as you can imagine. So this is a fungal lung infection. The initial infection is oftentimes in early childhood. 2/3 of healthy children have antibodies to this by age 2 to 4 years old. So once again, it's not just people with AIDS that get this. It's people with AIDS that their body can't fight this off. Signs and symptoms, very similar as before, but this one's a non-productive cough, fatigue with exertion, and then tachypnea, so breathing really fast. You should be suspicious of this as a clinician if you have a spontaneous pneumothorax in a person with HIV. So what is a pneumothorax?
Is bad.
It's the medical way of saying your collapsed lung. So air fills in between the lung and the chest wall, and then it kind of pushes against that lung, and it can cause the lung to partially or fully collapse.
It's what you see on all the TV shows where they
poke
a needle into their chest between the second and third intercostal space, and they say that on the shows, and they're like, put it through, find the intercostal space, and they stick it through. If you're thinking about that, that's what that is.
Yeah, great job. You're doing great, sweetie.
I learned about that in my mass casualty class.
And so we do see pneumothoraxes in traumas, and sometimes there is spontaneous pneumothoraxes in tall white guys who smoke. That's like your classic presentation of a spontaneous. But if we have spontaneous pneumothorax in a person with HIV, we should be suspicious of this PJP. If somebody's CD4 count drops below that 200, we should start prophylaxis for this specific disease. And I just thought this was really interesting. This specific disease is more common in heterosexuals than homosexuals and injection drug users, anything like that. We're seeing it in heterosexuals. Next.
Interesting.
Yeah, I thought that was interesting to add in there. Next is coccidioidomycosis. This is another fungal infection. It's most commonly found in the U.S. Southwest. And then its signs and symptoms are fever, cough, pleuritic chest pain, dyspnea, so just shortness of breath. You should be suspicious of this if you have diffuse pneumonia on a chest x-ray or a CT of the chest. Typically, pneumonia is in one specific spot, like right lower lobe pneumonia. If we're seeing pneumonia everywhere, we should be questioning why it's everywhere. Then there's histoplasmosis, which is most commonly found in the Ohio and Mississippi Valley regions of the United States, so central and south central United States. Its signs and symptoms are fever, cough, pleuritic chest pain, which means the chest pain gets worse when you take a deep breath. We call that pleuritic, shortness of breath or dyspnea, and then GI symptoms such as nausea, vomiting, diarrhea, and abdominal pain. CD4 count drops below 150. We should start prophylactic treatment for this. Then there's your neurological manifestations. So the first one that I want to talk about is toxoplasmosis. So this is the most common cause of a nervous system infection in immunocompromised individuals. This is actually the reason that pregnant women are not supposed to handle cat litter, is because the risk of transmitting toxoplasmosis to fetus. And so that's, if you guys haven't heard that, it's like still a very real thing that pregnant women are not supposed to clean out litter boxes.
I was so happy when I was pregnant and you had to clean all the litter boxes.
Yeah. And I started cleaning it when we started IVF. So I did it for a long time.
I know. That was the best.
Yeah.
Don't have that anymore.
What's interesting is this is seen with headaches, confusion, and lethargy. And I, once again, can't say that this is exactly where my mind would jump to when a patient comes in with those symptoms. There's so much else that I would think about first. But the good news is that when someone comes in with headaches, confusion, and lethargy, I am indeed CTing their head. And so we will catch this. And on CT, you're going to see ring enhancing brain lesions, and this should be the ding, ding, ding for you. If your CD4 falls below 100, that is when we're starting prophylaxis for this. Then there's cryptococcus. Not sure I'm pronouncing that right. Should have gave myself a little pronunciation guide. Once again, I have actually studied these so much because there's infectious disease on every exam you take and rotations. I just never had to say them out loud. So here we go. This is found specifically in the U.S. Pacific Northwest, and it commonly presents as subacute meningitis, so not acute, brand new happening, but not chronic. It's been going on for a long time, that phase in between, or meningoencephalitis. The symptoms we're seeing specifically for the cryptococcal meningitis is headache and malaise, so like nothing that you would jump to. So once again, high clinical suspicions. And if CD4 drops below 100, that's when we would start treatment for this. And cytomegalovirus, specifically the neurological manifestations of this, we're going to see encephalitis, so symptoms of delirium, cognitive decline, and somnolence. Once again, when patients come in with these symptoms, you're getting a CT scan anyway, so you'll find this on there. Unfortunately with this, oftentimes progresses to paralysis or rapidly becomes fatal. And this is as the CD4 count falls below 50. So you have to imagine at this point, you essentially have no intact immune system.
You got nothing. Your walls, they're down.
They're down. Next is GI involvement. So biggest thing in this is candidiasis, specifically oropharyngeal and esophageal. This is the most frequent GI opportunistic infections. And you typically see it in oral thrush, which are these painless, creamy white lesions in the mouth, and most can be scraped off.
That's disgusting.
Disgusting. But so there's actually a really big deal with this. If you ever find this in a patient, you want to go see if you can scrape it off. Because if you can, we feel confident that it's oral thrush. If it can't be scraped off, it's called oral hairy leukoplakia, which is also seen in HIV and can be the very first sign of HIV. And so I know that's not what we all imagine doing when we find something for the first time in someone's mouth, like, let me go grab a scraper. But we need to figure out, is this an AIDS defining infection, or is this one of the very first signs of HIV?
That's so nasty.
Yeah, you should look up pictures.
No, I mean, I will.
Yeah.
You're right.
Exactly.
The hairy part is really getting me.
It's not like its hairs growing in it. It's just
all I can imagine is like moldy fuzz.
I mean, yeah.
Gross.
And then with esophageal involvement, there's normally this retrosternal burning or discomfort. So essentially like your acid reflux with pain with swallowing. So nothing fancy, like nothing that as I kept going through this, I was like, how can I make my practice better? And it comes down to the social history, the past medical history, and having those relationships with your patients.
Yeah. So they got to be honest about that, though, which is, to your point, relationship building.
Yes. Next is mucocutaneous involvement or skin involvement. So disseminated varicella zoster virus can be multidermatomal or systemic. And if you're like, what the heck does that mean?
I am. What the heck does that mean?
So shingles so varicella zoster is shingles. And now let's all remember, for us people that are my age and older, that we all got chickenpox when we were younger. You didn't get the vaccine, did you? Did you get chickenpox? I for sure got chickenpox. My parents did not give me that vaccine. It came out in 94 off the top of my head. This is something you should know. You don't remember putting oven mitts on your hands so that you couldn't scratch your chickenpox?
Listen, we've been over this. My childhood memory is bad.
Is bad.
My memory in general is bad.
Okay.
I don't know. I'll ask my mom.
Yeah, we'll have to ask her.
Yeah.
So,
Mom, are you listening?
Are you listening? Is it Monday morning and you're listening to this podcast on your walk? So shingles in a typical immunocompetent individual, it presents in one dermatomal region, which the body has these dermatomes. And if you're ever interested in it, you should look at a map of it, because I actually think these are really interesting. But it will only affect this one dermatome on one side of the body. And let me tell you, as someone who despises rashes, despises dermatology, there is nothing better than when you walk into a room and you look at that rash. And it is the classic teardrops on a rose petal, which essentially means pustules on a red base. That's all it means. And it's in this specific distribution where it's not crossing midline and it's just in this dermatomal region, and you're like, hell yeah, that's shingles. Let me get you some
Nailed
medication,
it.
girl.
Nailed it.
No better feeling. But in an AIDS defining condition, we're seeing these not in just this one dermatome, not on one side of the body. We're seeing it everywhere, which is really sad because shingles is really painful, really painful. And then next is the Kaposi sarcoma, which is the cancer of the blood vessel lining, which we've talked about a few times. But what we see are these purplish brown lesions on the skin and mucous membranes that then spread to the lymph nodes and the lungs. This cancer has a very high mortality rate, unfortunately. And then I just want to put the eye one in there that I feel like we always get tested on in school is the cytomegalovirus retinitis, which is caused by herpes virus. So the same thing that causes cold sores on your lips. And these patients are seeing floaters, blind spots, and blurred vision. And then it rapidly progresses to blindness. And this is another CD4 count of less than 50. So low.
Would you take a moldy tongue or rapid blindness?
Moldy tongue. Are you kidding me?
Yeah, I know you're right. But I'm having like a very acute response to the moldy tongue.
I should pull up pictures for you.
Not right now.
Not right now. Okay, so story time. I was on an internal medicine rotation and I had this Ukrainian preceptor who I thought he hated me the entire rotation. But then he would make a comment then he had me come in on a day that he got called in because he was like, you're just so good and you're so fast at your notes. I can get out of there early. And it was like one of the first compliments he had ever given me. And I came home and I was like, oh my God, he doesn't hate me. And I just want to set the scene that this preceptor at the very end of my rotation, like sang my praises and then gave me the most average scores ever. And I was so mad because I worked so hard that rotation.
Wow, you're so average.
Yes. It was, do you remember? It was those average scores. And I worked so hard on this rotation. And then a few students that came after me in that rotation were asking me, like, what did you do to make Dr. So-and-so proud of you, to make him so happy? He talks nonstop about how good you were. And I was like, sir, you hated me almost that entire rotation. And then you sang my praises at the end. And then you gave me average reviews. And now you're telling other students that you actually liked me. Anyways, so this rotation, the whole rotation was a mindfuck. But I was reading on one of our patients I was reading an infectious disease consult note, and it was on a patient that had HIV. And the consult note was talking about how we should go ahead and start prophylactic treatment for PJP. And so I copied it and I said, like, per IND Rex, this is the plan. And he read it when he was reading over my notes to sign them at the end of the day. And he was like, where did you get this from? And I was like, oh, I just read infectious disease notes. And he said, I thought you were very smart, but maybe not. And I was like, oh my God.
No, I am smart because I looked at the notes.
Precisely, because I looked at the notes for the consult that you put in. And if you're not going to read your consult notes, you shouldn't ask for them. And then the other thing.
I thought you were very smart.
He said the wildest things to me. He had awful bedside manner. He was really smart. It was just this like language barrier.
Yeah.
But yeah, that rotation was something else. Okay. Anyways. There's also this other thing that I wanted to talk about, which is immune reconstitution inflammatory syndrome. And it essentially is this paradoxical worsening of a known opportunistic infection or an unmasking of an undiagnosed infection after ART initiation. So this is most common within the first 6 months of treatment, which is such a long time to be like constantly thinking about this. And if there's this severe opportunistic infection and then we rapidly start treatment, it can result in this. And so in order to prevent this paradoxical worsening, the opportunistic infection should start being treated before we initiate the HIV therapy in order to decrease the chance of this.
How long does it take to treat some of these?
Most of them an incredibly long time, and most people are on lifelong medication. So I think it's more so about stabilizing the infection than fully treating the infection.
That still sucks though, because you're like, I'm ready to start treatment. You can't start it because you have PJP or whatever, and then you got to treat that first.
So we've talked about this coming out of the opportunistic infection world. I know that was a lot, but there's just so much to know and so much for clinicians to be on the lookout for. Without therapy, HIV will progress to AIDS and will be fatal. With therapy, we see a prolonged life expectancy, and sometimes it never progresses to AIDS. But we still know there's no cure for this. Okay, prevention. Let's step on a soapbox. How are we preventing this now? And Bernie talked about how some of this all started, but education, education, education. So educate your patients about HIV, about how it's transmitted, about the importance of medication adherence so that they can get to an undetectable viral load and not pass it on to other people. Educate them about using protection, specifically condoms, so that we have a barrier protection. So if you have a female that has an IUD in, and they think they don't need protection because they're only thinking about pregnancy, it's really important that they know that there's still this chance of them getting these other STIs. And I think that's really misunderstood, especially in young women. Like, I have my birth control, I'm good to go. And that's not true. There is pre-exposure prophylaxis. So for patients that have high-risk sexual activities or would just like to be more safe than sorry, they should really be started on this medication. And so once again, make sure you have that relationship with your patient so that they feel comfortable asking you for this. There's also post-exposure prophylaxis, which has to be given within 72 hours of that HIV exposure. This is kind of hard though, because most people don't know that they've been exposed to HIV, so it should not be used as a standalone practice for preventing it.
Yeah.
And then, of course, avoid sharing needles or other drug injection equipment. Most people don't go out there planning to share needles, but I think that's why it's really important to have the safe disposal boxes so that other people aren't accessing them or accidentally nicking themselves with one they didn't see on the floor, et cetera, et cetera.
Because addiction is horrible and scary. And so you're willing to do anything at some point. At some point. It may not be the first time around, but the second time around, maybe. And you see that needle that's laying on the ground, you might just be willing to take that chance in order to be able to access, what makes you feel good.
What gets you out of pain? A lot of my patients, when I ask them, why are we using IV drugs? And they're like, it's the only thing that stops the pain. And they have a real reason for their pain. So sure, I'm not saying that it's a good thing to use IV drugs, but I think it's important also that we ask our patients, why? Like, why do you feel like you have to do this?
Mm-hmm.
Some people are using IV drugs solely so they can stay awake, so that people aren't coming to kill them or rob them.
When they're homeless.
When they're homeless, specifically. Yeah, I should have said that. When they're homeless. And we just have to remember, like, they have much different risks and they live a very different life than we do. Yeah. Okay, I've talked about this a lot in different pieces, but I really want to bring it home for like, what should we be doing as clinicians, as anyone that's a part of our care team? A, take away the stigma. Talk about it as if it were another diagnosis, as if it was another STI. Just talk about it and ask your patients. Ensure we're asking a proper past medical history and social history so that these patients will actually tell us when they have it or the possibility of high-risk sexual activity or drug use or anything else so that they've been exposed to it. Routine HIV testing. One thing that I need to get way better about in my practice is when a patient asks me for STI testing, I typically do a wet prep, which is trichomonas, yeast, and bacterial vaginosis, gonorrhea and chlamydia, and syphilis, because rates in our state are so high for syphilis that it automatically reflexes for me for this. But I'll be honest, I very rarely order an HIV unless a patient specifically asks me to. And I need to specifically ask them if they want the HIV. Like, hey, do you want to do the whole shebang and do this whole panel?
Yeah.
And that's something that I need to get better about as a clinician. Have a high clinical suspicion if a patient is coming in with these recurrent infections with high risk activity. Just when your spidey senses start going off, those spidey senses are real. And we just need to start asking some more direct questions of our patients. And then if you know your patient has HIV, whether they're your patient in the office or your patient in the emergency room, are they taking their therapy appropriately? Are they taking it every day? Are they trying to spread it out because they don't have the money to pay to take it every day? Or, once a month? All of these medications are different. Do they have access to their care and for their medications, whether it be getting to the pharmacy, getting there for their refills? When was the last time they had their CD4 and viral load check? And that CD4 is really important for us in the acute care setting to understand, like, what are our possible infections that we need to be more diligent about checking. And then help break down barriers to care. Get case management involved if needed. These patients need to stay consistent and involved with our system. So any barrier that we can break down and help them with, we need to do. Even if that's, hey, I know you probably can't make it in here for 6 months, a year, even though I'd really like to see you every 3 months, I'm going to go ahead and refill this for 6 months or for a year, because it's more important to me that you're taking your meds if you can't get in to see me. And I know that's not ideal. I would love to see my patients more if I was working in a private, in a primary care office, but sometimes it's not possible for them. Busting myths. You cannot get HIV from handshake, hug, or a closed mouth kiss. Kiss away. Contact with objects such as like toilets, doorknobs, like those high touch objects. Can't get it.
Nope.
Biting insects, there was this myth that like maybe ticks or mosquitoes were giving people HIV and AIDS. Not possible. Sexual activities that do not involve the exchange of bodily fluids. If we're just, at first base, halfway to second base, have fun.
Yeah.
Have fun, my friends. And donating blood. There are safe practices when donating blood. You cannot get HIV from donating. HIV in today's world. So Bernie
It's
stopped
still
about,
here.
yeah. Bernie stopped about 2000. So in 2022, the CDC estimated there was 1.2 million people in the United States that were still living with diagnosed and undiagnosed HIV.
Wow.
1.2 million in the United States alone.
That's insane.
That's insane. Globally, in 2024, it's estimated that 40.8 million people are living with HIV. 31.6 million of these people were accessing antiretroviral therapy. 1.4 million people of that 40.8 were children age 0 to 14. So if you're telling me that a 2-year-old having sexual practices or injecting drugs and it's their fault that they got HIV, fuck off.
You're wrong.
You're wrong.
You're just straight up wrong.
Yeah. And then I really want to point this out. As of 2024, 53% of these people were women and girls. So this is not a gay men disease.
Yep.
In 2024, there were 630,000 people that died from AIDS-related illnesses. So we're still seeing a significant amount even to today, even with accessing therapy and doing better about checking and all of these things. We're still failing these people because this is preventable. There's a ton of stigma and discrimination due to the history of HIV and AIDS, which Bernie went so much about, and this misunderstanding and bias that leads to delay in care, whether it be from the clinician or from the patient. Countries with still relatively high amount of HIV, Eswatini, I might be pronouncing that correct, 23.4% of their population is diagnosed with HIV. South Africa is 17.2% of their population, and then Lesotho is 17.1%. And the causes in most of these countries is there's human rights violations, there's military conflicts, and there's poverty limiting access to treatment. Once again, this is treatable, not curable, treatable. And we're withholding that in some way or another. And that really makes me sad. Like who's at fault?
Yeah.
Ethics autopsy, we're back. I feel like this whole episode is an ethics autopsy. So we'll kind of skirt through a little bit of this, but the whole thing is an ethics autopsy.
Yeah, I mean, we mentioned it multiple times about just the early names of GRID, gay cancer, gay plague, 4-H disease, just associating the illness with minority groups, which ended up not being the case, and not caring about acting on it because it's minority groups and it's not affecting you.
Yeah, and there's just less urgency to respond when it's not affecting you. And that leads to like, we were deciding whose lives were worth saving. We didn't feel like the minority groups were worth saving. And so it led to this lack of action and it being delayed. And that's really sad that we're putting one person's life above the rest.
Yeah.
Yeah. Or below the rest, I guess I should say.
Right.
The healthcare system, patients were refused treatment. There was not an understanding that as clinicians, we have a duty to care, not to moral judgment. Healthcare workers also feared contagion despite growing evidence about transmission. So even though we knew how to prevent this, healthcare workers still used it as an excuse
Not to treat
patients, which just makes me really sad.
Yeah, I didn't put it in here, but I did read about specific hospitals where healthcare workers would just walk out and leave like debilitated patients in their beds and not take care of them.
Yeah.
Because they were scared of getting the disease, even though they knew that they couldn't get it.
Yeah. Like if you want a double glove, that's fine.
Yeah.
And then we kind of talked about drug access earlier, but like the first drugs came out and they were unattainable.
Real expensive.
Yeah, unattainable to, I would argue, the majority of the public. Activism was what shaped medicine instead of our government, who is for the people, being what shaped this medicine.
Basically, AIDS and HIV sucks. If we had to choose to cut it or keep it, we're obviously cutting it. And we're cutting the lack of involvement and lack of action from government agencies and health organizations that ignored the minorities and really prolonged the suffering.
Yeah, all right. So just a conclusion, bringing it all back together. This is a disease that affects everyone, all ages, all races, all sexuality types.
Mm-hmm.
Like this does not discriminate. And it makes me really sad because I think a lot of people still think it does discriminate and it won't affect them.
Yeah.
And they don't realize that like there's still a chance in your blood transfusion that it could be given to you. Now there's a really low chance.
Yeah, now. Nowadays.
But there's people that got it that were doing life-saving treatments or just doing treatments in order to keep up with their quality of life, and they were still shunned, such as a 13-year-old that had to leave school. And so just remembering, that this is not a minority issue.
Yeah, absolutely. Alrighty.
All right.
Now that we've talked your ears off for your whole entire drive to and from work,
you can follow us on Instagram at _cadavers_lessons. You can follow us on TikTok at _cadavers.lessons. On YouTube, you can now watch these at the Cadavers Lessons. You can support us financially at buymeacoffee.com/the_cadavers_lessons. You can listen on Spotify, Amazon, and Apple. And then please, please, please leave a review, comment, share our podcast, engage with anything that you see online with us.
If you have an idea for an episode or a case, DM us on social media. Also, if you have a fun story or not so fun story that you would like to share with us and have us share on the podcast, DM us that story as well.
And then sneak peek of next week's episode, we are doing bloodletting and then likely adding leeches to that. So I'm super excited. All right, Cadaver Crew, class is dismissed.
Stay safe.
Stay curious.
And don't try this at home.
Unless you own a bone saw.
Later.
Thanks so much, guys. This podcast is for educational and entertainment purposes only. We discuss the history of medicine, not your personal medical situation. Nothing you hear on this show should ever be taken as medical advice, diagnosis, or treatment. Some of the information discussed may be incorrect or become outdated over time. We do our best to stay current with medical knowledge, but medicine changes quickly. Additionally, because we do not work in every specific field we discuss, there may be times when we misspeak or misinterpret information. We're all human and we're doing our best for the podcast. Every medical case is unique, and your health decisions should always be made in consultation with your own qualified healthcare professional. If you have any questions or concerns about your health, please reach out to a licensed provider who can give you guidance based on your individual needs.